So this is a curvilinear probe which is not recommended, and the recommended probe is high frequency linear probe, and the patient position should be important, that the neck should be properly extended with the pillow under the shoulders to expose the neck, and then this is how the thyroid on ultrasound looks. This is the right look. The thyroid has a uniform echoes, and that is hyperechoic as compared to the strabismus intelligence. This is the trachea, isthmus, right lobe and the left lobe of thyroid, and these are the carotid arteries. So this is the medial to carotid and lateral to the trachea. So UST again is the key to identifying and stratifying. It has a sensitivity from 55 to 95%. And thyroid scoring system was introduced in 2009, and then it has been evolving over since then. And FNAC is the next modality of choice, where the sensitivity is 65 to 90%, and it will be based on the expertise of the person who is doing the FNA and the cytologist. So, which nodule should do FNA, which how to approach multinodular goiter. So it has evolved over a period of time. The Society of Radiologists in 2005, and then thyroid classification has come in 2009, and then there is modification. And the latest is the ACR thyroid white paper, based on which we will stratify this nodule. And these features, which are the features which we will evaluate, is the composition, echogenicity, shape, margins. We'll see each one of them. So it's difficult to remember all these points. So even in Tata, what we do is take a printout, laminate the paper, put it in front of us, and then see each feature, and then see the scoring system. Then that's the easiest way to calculate. You see the composition, echogenicity, shape, margin. Each one will see individually. So composition again, whether cystic or spongiform or solid or cystic. Echogenicity either hypoechoic or anechoic. Shape, whether it's taller than wider, or and margins, whether it's irregular, smooth, or exothyroid extension, and echogenic foci, whether they have punctate echogenic foci, macro or micro calcification. So if you see each has a one, you have to choose one point from each one. But the final one, the echogenic foci, if at all if the nodule has a macro calcification and punctate echogenic foci, all these things will add up. So based on the total score, it will be thyroid 1, 2, 3, or 4 or 5. So if you see thyroid 3 is 3 points, thyroid 4 is 4 to 6 points, and thyroid 5 is more than 7 points. So each feature will see individually. Composition, whether it is cystic or solid. So if you see, this is a solid nodule, this is predominantly solid nodule with a cystic. So when you say predominantly solid, if 5%, if the ATA ACR guidelines says that if the cystic component is less than 5%, then it is predominantly solid. And this is a mixed solid cystic. So if you see, this is the cystic component, this is a solid component. And this is predominantly cystic, and this is completely cystic with commutative artifacts. So you can see the solid component, any solid nodule, even though if it is benign or malignant, we are not classifying it as, we will just give it 2 points, and mixed solid cystic 1 point. And if NA has to be done, it has to be done from the solid component of it. And once you call it as a spongiform nodule, what is spongiform? It is like a sponge, multiple small tiny cystic areas within. And once you classify it as a sponge, and it will not go further. So that is the end of the evaluation. Spongiform nodule, there is no further points for anything. So echogenicity. Again, whether echogenicity is whether how it is the reflectivity. You will compare it with the adjacent thyroid gland, and you will see whether it is hypo to the adjacent, or iso, or hypo. So if you see, this is hypoechoic. Hypo means dark. If it is darker than the adjacent thyroid gland, then that is hypoechoic. So the darker it is, the more suspicious it is. So the brighter it is, then the less suspicious. So you have a feature hyperechoic or isoechoic. So you need not worry that whether this is iso or hyper. So both have 1 point. So if you are not sure whether it is hyper or iso, you just give it 1 point, and then if it is hypoechoic, you will call it as, you will give it 2 points, and if it is very hypoechoic, how do you classify this very hypoechoic? When you compare it with the strap nodules, and it is darker than strap nodules, then that is very hypoechoic. And shape, either it is wider than taller, it is 0, and it is taller than wider. When it is taller than wider, that is, this is wider than taller, and this is taller than wider. So when this is the anterior posterior, this is anterior and this is a posterior. When the nodule goes anterior to posterior, then that is taller than wider, and it has 3 points. That is a highly suspicious feature. So you can see another example where there is a taller than wider nodule, which is a suspicious feature. If it is round, what will it give? So if at all, if it is round, you can call it as wider than taller or not taller than wider. So it will still have a 0 points. Again, margins, if at all, if it is ill-defined or smooth, it is 0 points. So sometimes the nodule can be very ill-defined. You are not able to identify whether it is irregular or smooth. Then give it 0. If it is well-defined, there is no what do you say that irregularity here. So that is again 0. Again, this is well-defined. And if you see, these are lobulated margins. And if you can see this lobulations, then that is 2 points. And if it is extrathyroid extension, see, this is the thyroid doesn't have a capsule, so the pseudo capsule is a bright line. And if it is breached, the nodule is going outside the thyroid, that is the extrathyroid extension. So echogenic foci, again, echogenic foci, they are classified if it is more than 1 millimeter, that is a common-tail artifact, which is a benign colloid feature. See, this is more than 1 meter. And this should be in cystic component. And if at all, if you see a very tiny echogenic foci within the solid component, those are punctate echogenic foci, which is a suspicious feature. This is a peripheral rim calcification, and because of the shadowing, you are not able to identify what is inside the nodule. So you will consider it as a solid nodule and give the points accordingly. So echogenic foci, like I said, they are punctate echogenic foci. Now we don't call it as microcalcification, but we call it as PEF, punctate echogenic foci, and this carries 3 points. See, if it is a solid nodule with multiple punctate echogenic foci, this is a highly suspicious nodule. And the calcification, there is no role, there is no points in the calcification, only it helps us whether it is a solid or it is a debris in a cystic component. So you can see there is a solid nodule with the peripheral and central calcification. So this is the various categories which I have explained to you. And when do we do FNA? And these are examples where we give how this is how we score it. So it's better to keep a chart in front of you, just circle it, and then it's instead of giving a descriptive report, you ask for your radiologist that please tell me what is the score and how did you score it. And then you should be able to identify that if he calls it as a hyperechoic and do a FNAC, then that's the wrong thing. So what is the size criteria for each one? I tell you. So if at all the previous ATA guidelines says low risk or low suspicious. For example, Thyroid 3 nodule, if it is more than 2.5 centimeters, FNAC is recommended. And if it is Thyroid 4 nodule, more than 1.5 centimeters, FNAC is required. And Thyroid 5 nodule, now even though you say Thyroid 5, if it is less than 1 centimeter, you need not do FNA. Only if you are planning to do a surgery, then FNAC is recommended. If at all, if it is an active surveillance, then FNAC is not recommended according to ADI guidelines. So the risk of malignancy is very high if it is solid and hypoechoic with multiple punctate echogenic foci. And the cystic component, as the cystic component increases, the risk becomes low. So FNAC categories are varies, but for 3, if it's a class 3 nodule, then more than 2.5 centimeters only, the FNAC is recommended. So again, for a USG features of malignant node, like I said, it's a loss of fatty item and echogenic foci within necrosis, then that is again a suspicious node. How do we do FNAC? These are some guidance. And if at all, if you see the sensitivity of FNAC, it is 97 to specificity is 96%. And the recommended gauge is 25 gauge. The smaller the bore, the better the yield it is. So the wider the bore, the chances of blood going into the needle and causing a false negative, it will be there. So this is how we do FNAC. I'll show you we have a rose technique and in-house cytologist who will be present at the site of FNAC. We remove the sample and give it to the cytologist. And FNAC, 3 passes can be done on the for FNAC. And there is a parallel versus perpendicular technique. I'll show you the techniques. So this is a parallel technique. This is parallel to the probe, where the complete needle is seen. But if the needle is located deep, then you can use a perpendicular technique only where the tip of the needle is seen. So the needle is perpendicular to the ultrasound beam. So aspiration and non-aspiration technique. Non-aspiration is recommended. You need not aspire. Negative suction is not required. So just put in a needle, pass 3 times, and then take it out. The sample will be there. With the capillary action, you will get the cells. So technique is either whirling technique, where you rotate the needle inside and then to and fro motion. So this is called the to and fro motion technique, where you pass in the needle and then this is a again to and fro motion. This is a whirling technique where you just rotate the needle. So you pass 2 times, 3 times and then whirl and then take it out, the sample will be adequate. So this is a needle gauge, and then studies have been done which is the best needle gauge. 25, the orange color spinal needle is better. And how we do the smear, we prepare the smear on site, and then the cytologist will be there who prepares the smear and then fixes the smear. And there is one slide which is air dried, and then one is stained immediately, rapid staining, and seen under the microscope, and then for the sample adequacy. And if the cytologist says that the sample is not adequate, we'll again repeat the sample, so that the negative test is very less. So when the cytologist says the sample is not adequate, we'll again re-aspirate, and the cytologist write it as adequate sample and send it for analysis further. So for all the FNACs we do this one. So rapid on-site examination. So again, targeting the solid component is important, and the Bazista classification I will tell regarding this one. And when do we use CT? When there is a frank extrathyroid extension, and then you are contemplating anaplastic thyroid or a medicinal extension, then the CT will help us. And if you see, this is the ETE grades. The higher the ETE grade, then the chances of infiltration of the surrounding structures is high. So this is an example of the CT. This is ultrasound. This is MRI, where MRI, if at all if you are thinking that perivertebral fascia involvement is there, then MRI is recommended. This is a large thyroid nodule, thyroid tumor, which is infiltrating the esophagus, extending the tracheoesophageal groove and the prevertebral fascia. So prevertebral fascia involvement, we see it on cross-sectional imaging. And shin grading is also important, where you see the infiltration of the trachea. You see if it is, this is shin 1, and this is shin 2, where the cartilage is involved, and shin 3, where it is extending up to the mucosa, and then shin 4 is frank infiltration of the mucosa. So these are various examples of the shin. So you are in the cross-sectional imaging. Shin grading is important, and the number of tracheal cartilages to be removed also will be based on the cross-sectional imaging. And nodal metastasis is, we have to see lateral compartment, bilateral or unilateral, and central compartment. The mention of central compartment is also very important, so that they will be addressed at the time of the surgery. So post-treatment imaging, again, this is a very difficult topic. You see fibrosis might appear as a nodule, and then you should be able to differentiate it, and this is a recurrent nodule in the thyroid tract. This is a follow-up case of hemithyroidectomy on the right side, and the left lobe of thyroid has a nodule which was initially detected as benign, but on follow-up imaging you can see there is an increase in size which on FNAC proved to be suspicious. So follow-up of the opposite lobe of thyroid is also very important. And then thyroglossal duct is incidentally found. You also look for a carcinoma in the thyroglossal duct. This is a thyroid reflect MRI. And aberrant subclavian is very important for the surgical consideration when you are planning to do intubation or non-aberrant, non-recurrent laryngeal nerve. For this subclavian artery should be there. And then our surgeons always ask for the course of the carotid, whether it's retropharyngeal or parapharyngeal. That also has to be mentioned. So the radiologist plays a very important role, and then you have to demand what you want. Otherwise, the radiology reports will always be suboptimal. So once you know that what is it you want and how you are, if at all if the report says there is a thyroid nodule and FNS is suggested, you should ask what are the suspicious features based on which your FNS is recommended. So you should avoid unnecessary FNS and then only target those which are suspicious. Okay? Thank you.